Uttar Pradesh is India's most populous state, and it has some of the worst health outcomes in the country, including really high rates of infant and maternal mortality. In Uttar Pradesh, or also known as UP, as in other parts of rural India, the government relies on trained community healthcare workers to link households and the health system. In India, these are referred to as ASHAs. So these community healthcare workers mobilize families to seek and access appropriate care. They provide counseling and information on healthy behaviors, and they also distribute commodities. Despite large investments by the government in ASHAs, they're actually operating well below their potential, often only performing select activities asked of them. So we wanted to step back and ask a really fundamental question, which is, how can we empower community healthcare workers, or ASHAs, to serve their community more effectively? There's a lot of different programs and policies that have aimed to shift what an ASHA is doing. So for example, trainings or different incentive structures or increased supervision and monitoring. But these interventions actually haven't led to behavior change at the level that's needed to get to the desired impact on outcomes. By outcomes, I'm meaning mortality. To create lasting change, we really need to understand why ASHAs are doing or not doing certain things and what's the context in which they're making these decisions. We turn to cubes to really holistically explore all of the different factors, barriers, enablers that are affecting what ASHAs are doing and the context that's shaping her behavior. Cubes really informed all aspects of the design. So first we use cubes to guide the literature review and really identify what's known and where the gaps exist. So after mapping all the existing literature on ASHA performance onto cubes, we actually recognized we needed to go deeper. And so we took a mixed methods approach, first conducting qualitative research and then quantitative research. In the qualitative research, we attempted to really understand all the potential factors that are driving ASHA performance, how she's interacting with the community, what is the system, how is the system actually impacting what she does and why she does them, what's her personal motivations and beliefs. And we did that both using journey mapping and structured immersion interviews. A number of the things that came out in the qualitative research, we felt like we really needed to quantify. So for example, several ASHAs had told us that delays in receiving their incentive payments were actually really demotivating and causing her not to perform all of the things that she should and could be doing. And so we said, okay, we really need to quantify this. So we turned to, we developed a large instrument where we surveyed 1,500 ASHAs across the state of Uttar Pradesh in a statewide sample. Cubes there was central to the study design in that it didn't tell us necessarily what are the questions to ask, but it really serves as a checklist to help ensure we had all the questions that covered all of the different drivers of behavior. I mean, we learned a lot about what's driving ASHA behavior, but the big thing that I think really stood out is not all ASHAs are the same. So when we looked at the quantitative study of 1,500 ASHAs, we actually turned to a technique that's commonly used in the private sector called psychobehavioral segmentation. So using artificial intelligence, we were actually able to segment all of the 1,500 ASHAs into 5 different groups. These groups all differ both in their performance, what are they doing, but more importantly, why, what's driving their behavior. And this showed us that we need a more tailored approach to training and development of ASHAs in the workforce. So for example, there's a group of ASHAs that are financially troubled. They don't need more clinical training. They actually really need support in getting the incentives that are due to them. And if they felt reassured in that front, it would actually enable them to do more in their community. There was another segment of ASHAs, though, that were highly motivated, but lacking particular types of clinical training. And so these women don't necessarily need to be monitored or pushed to work more hours, but they actually needed to be given enhanced clinical training. One cool thing with the data is that you can actually ask 3 to 5 questions on a piece of paper, and I'd be able to identify which segment an ASHA belongs to. So you can imagine an ASHA supervisor being able to have a conversation with a member of her workforce and then be able to, maybe refer them to the right type of training, or maybe be able to provide more tailored, targeted hands-on support to around the incentive process. Zooming out from this, there's a lot that we can take away from this approach, and the need to really understand how communities are different, how people are different, and move beyond one size fits all approaches to target particular interventions to particular communities that need them the most.